Hi, this is Alsagban, PGY2 internal medicine resident of Canon Vista Medical Center in Sierra Vista, Arizona. Here, I would like to present my case report for thyrotoxic periodic paralysis that we encountered recently at our facility. I included a brief description of thyrotoxic periodic paralysis and the importance of reporting such a case at the end. Thyrotoxic periodic paralysis is a complication of hyperthyroidism, increasingly being seen in the Western countries. Thyrotoxic periodic paralysis is most common in Asian populations, with an incidence of approximately 2% in patients with thyrotoxicosis. It has been recognized in Filipinos, Vietnamese, Koreans, Malaysians, Hispanics, African Americans, and Caucasians. Hypokalemia and muscle paralysis results from sudden intracellular shift of potassium, and it's not due to potassium deficiency. Clinical features of hyperthyroidism in patients with thyrotoxic periodic paralysis may be subtle, and factors such as stress, steroid, binge alcohol consumption, and exercise can precipitate an attack of thyrotoxic periodic paralysis. Now up for the case. 23-year-old Polynesian gentleman with no past medical history who presented to our emergency department with a complaint of flaccid muscle paralysis for 12 hours at home. The patient reported 3 previous similar episodes that self-resolved without intervention and for which he never sought medical attention. Physical examination on a presentation showed patient's lower and upper extremities were weak, with 1 out of 5 strength in the lower extremities and 1 to 2 out of 5 in the upper extremities. Muscle weakness was more apparent in the lower than the upper limbs. Otherwise, physical examination was unremarkable. Workup showed potassium of 1.7 MEq per liter and a phosphate of 1.1 mg per deciliter. TSH level was less than 0.03 and T4 free level was 2.7, while T3 free level was 8.09. Thyrotropin receptor antibody level was 5.88 and EKG showed normal sinus rhythm with a QTC of 576. Imaging, including thyroid ultrasound, showed 0.5 cm nodule on the right hemithyroid. Differential diagnosis included familial hypokalemic periodic paralysis, thyrotoxic periodic paralysis, Guillain-Barré syndrome, to name a few. The intervention in the ED was including 60 MEq of potassium that was given orally, after which the patient went up after frequent potassium checks from 1.7 to 5.5 MEq per liter throughout the night. That was confirmed with repeating the potassium level. Careful replacement was practiced and frequent potassium checks was done. And EKG after the intervention showed improvement in the QTC down to 404. Patient started to regain his strength slowly overnight, and in the morning he was able to ambulate without assistance. On discharge, patient was educated about the most important factors that can precipitate his attacks and started on methimazole 5 mg twice daily and referred to endocrinology service. Diagnosis was confirmed and toxic thyroid nodule was diagnosed, and by the last follow-up appointment in September, no more episodes were encountered. Now for the discussion. This case highlights the importance of conditions encountered more in foreign countries that are rare in the United States and more specifically in the rural medicine. Hypokalemia and muscle paralysis resulted from sudden intracellular shift of the potassium and is not due to potassium deficiency. Therefore, careful replacement and checks should be practiced. Intervals of weeks to months are common, but some of the patients experience several attacks per week. For the treatment of an acute attack of thyrotoxic periodic paralysis with severe weakness, recommendations include patient to be on a cardiac monitoring and a potassium level to be checked and monitored for a potential rebound hyperkalemia for 24 hours. Suggested protocol is a potassium replacement with 30 MEq every 2 hours, with a maximum dose of 90 MEq in 24 hours. Oral administration is preferred if possible. As with hypokalemic periodic paralysis, attacks in thyrotoxic periodic paralysis can be precipitated by events that can be associated with increased release of epinephrine or insulin, and both of which can cause movement of potassium into the cells and low potassium blood levels. Most commonly, the inciting events is either rest after strenuous physical activity, stress, or a high carbohydrate load. Most importantly, thyrotoxic periodic paralysis is a treatable condition and it can be controlled once the thyrotoxicosis is treated. In acute attack, thyrotoxic periodic paralysis must be distinguished from other causes of acute quadriparesis, like myasthenia crisis, Guillain-Barré syndrome, acute myelopathy, like transverse myelitis, tick paralysis, and botulism.